We're going to start off this morning with an introduction of a colleague and friend, Dr. Andrew Healey. Andrew is an emergency medicine physician, an intensivist. Andrew's had extensive training, international masters in donation in Spain, and he is currently the Chief Medical Officer at Trillium Gift of Life. He practices emergency medicine at St. Joseph's Hospital in Hamilton and is the Associate Clinical Professor in Emergency Medicine at McMaster University. Andrew is the Division Head and Medical Director for the Division of Critical Care at William Osler Health System. He's going to speak to us this morning about restarting the heart after DCD.
Thanks, Mike, and thanks for the opportunity to speak to you this morning. So I'm going to talk about restarting the heart after death in DCD and the consensus building process that we've undertaken over the last number of months. Just two disclosures: I receive a stipend for my role as Chief Medical Officer at Trillium Gift of Life Network, and we received an educational grant to travel to Papworth to learn about DCD hearts from Astellas. So I'm going to try and take us through the journey, how we got here, how this is done, what are the death determination considerations here, what is the international experience to date. I'll share with you a brief summary of a public and professional survey done by our colleagues, and then I'm going to talk about the key findings that we came to at our meeting. So how did we get here? This began with motivation on the part of the transplanters this process began with the motivation of the transplanters in Ontario to address the idea that hearts could be donated after DCD. We took a trip to Papworth, as I explained to you earlier on, and learned what the Papworth technique was for DCD hearts, explored their concerns, explored the protocols that they did there, and we came back. You'll remember last year at the Deceased Donation Symposium, if you were there, hearing from Mr. Large, affectionately now known as Mr. Big, apparently, from the UK, Peter MacDonald from Australia, who presented their perspective, and then Darren Freed in Edmonton, who has a full research program devoted to the resuscitation of the heart following cardiac arrest ex situ. We reflected on this question: could we just move forward in Ontario? We reflected on this question, and when we reflected, we paused because we realized that we were talking about interventions in donation that were going to impact our death determination framework, and did not think that provincially we should do this. We thought that this would be better led by a group that had led many leading practices before. And so, as Sam affectionately did, he answered my phone call at 8 o'clock one night when I said, I just need you to devote a bunch of money to this project and try and answer the questions about death determination in DCD heart, because there are transplanters motivated to save more lives. And we were met with a collaborative answer. In June of this year, you met Stephen Bede yesterday. Steve called me and said, we have a patient in Nova Scotia, a baby, who was born with tracheal atresia, which is not fixable. And the heart transplant surgeon at Sick Kids had said, we can't fix that problem, but if there's a consent to withdraw invasive support, that is, the baby was on ECMO at this point, could we move forward with DCD heart donation? And we worked through that evening with the help of people at TJLN, the help of the people at the IWK and at Sick Kids, and essentially these parents were able to consent to withdrawal within hours of the birth of this baby, consent to transfer to Ontario, and consent to heart donation, which would have been the first in Canada. And the only thing that didn't get us there was the suitability of the heart. So we were really close to realizing the first DCD heart even before this meeting. One of the things that always leaves us as donation professionals with some pause is this idea that when we have consent, how do we recognize that that is actually the gift to the family? So we invited this family to join us for the meeting just 4 months after the death of their baby. And I have to say, it was one of the most profound experiences many of us have had to date in patient and family partner engagement. They were full contributors at our meeting and were able to talk to us about what it was like to consent for DCD Heart and what it meant to them when that couldn't happen. And so I hope to do William service today. I want you to understand this is not a clinical practice guideline. It's much like the guidelines you hope your children will follow. There's no authority to this, but it is expert advice that is gathered in a multidisciplinary way from a very large group of professionals, from bioethicists to perfusionists to cardiac surgeons to non-cardiac transplant surgeons, death investigators, organ donation organization specialists, neurocritical care specialists, legal and ethics, and cardiologists, and our nursing colleagues and perfusionists. We had a significant patient and family engagement strategy thanks to members of our planning committee. There were heart transplant recipients, a family member of a DCD donor from Ontario, and the gentleman on the far right is Tom, who you'll see in a video at the end of the talk. He was the second DCD heart transplant recipient in Papworth. These are the two donors which were represented by their families during our meeting. The question becomes for us, how is this driven by need? And I think you've seen this slide a number of times, but we've seen a significant increase in donation over the last 10 years, largely on the backs of DCD performance. And the one organ that will not benefit from that is heart. And so this group of potential recipients are at a disadvantage if we can't access that resource. In Canada, we do about 163 adult heart transplants a year. I use "we" really loosely there. And we do about 23 pediatric heart transplants per year. The question is, what's the urgency to this? And I don't think it's a mystery to us that there are deaths on the transplant list. In the adult heart transplant waiting list, there's about a 20 to 25% death or withdrawal rate. And in the pediatric heart transplant list, there's about a 30 to 50% withdrawal rate. I want to reflect on one important other motivator on how we got here, and understand that Dale Gardner, who's one of our donation colleagues in the UK, has reflected that no families who have been approached for DCD who said yes for DCD said no to heart donation. I think that's important, and I think many of us have had the experience where a family regrets not being able to donate the heart, and so that is yet another motivator for how we get there. So now I'm going to talk about the protocols, about the two possible ways in which this could be done. As we do that, I want you to keep in mind three particular DCD scenarios, and one that is uniquely Canadian. The typical DCD donor is the profoundly brain-injured patient from which you withdraw invasive physiologic support. The less typical, but does happen in other jurisdictions, is the withdrawal of non-invasive ventilation in a conscious, competent patient, for example, with ALS. And in a uniquely Canadian way, and the reason this is important is this, by definition, requires a patient to have essentially a normal brain. And so this elevates our quest for ensuring that death determination remains solid. So this is the donor following administration of medical assistance in dying, of which we've now had a considerable experience in Canada. I also would like you to reflect on this case as we think about the death determination issues here and the protocol that I'm about to share with you. So imagine a typical DCD donor where you have withdrawal of invasive physiologic support with DCD consent. You have circulatory arrest and a 5-minute observation period. You go to the recovery room, you go to the recovery operation, you have a rapid sternolaparotomy, as is usually the case, and there's a pause on the part of the operating room team because there's heart motion in the operating room, even though the arterial line remains flat. So absorb that just for a second and think about what that means for you when it comes to whether that patient is dead or not. The most important comment for us that framed our discussion about this issue at the beginning of our meeting was made by Stephen Large. And I think importantly, he said, in order to transplant a heart, we have to accept the heart is going to beat again. And if we can't accept that, it's just as well for us to go home. The question really we're going to answer in a moment is, where is that heart going to beat again? These videos are courtesy of Darren Freed, and they show you what the heart looks like as it goes through this process of withdrawal of invasive support. So at the beginning of withdrawal, this is a video that shows you the physiology of the heart. You get a vigorous contractility. You eventually go through this period of hypoxia, ischemia. You get distension of both the right ventricle and the left ventricle. You get injury to the myocytes, and you get hypotension. And then eventually you get to a place where you have cardiac arrest and no forward flow. And then, in order to proceed with DCD heart transplant, we have to resuscitate that heart and take the heart back through that journey it's just gone through and resuscitate it in the best way it can so that it can be restarted either outside the body or inside the body of a recipient. So where is the heart going to be restarted in DCD hearts? So in everyone, it will be restarted in the body of the recipient. We know that. I mean, if it's not, we've failed, the transplant has failed. Another protocol that is the only protocol exclusively done in Australia is where the heart is restarted outside of the body and then in the recipient. And that is under a protocol called direct procurement and perfusion, or DPP, with ex situ evaluation. The other option is that the heart is restarted inside the body of the dead donor and then the recipient, and not restarted outside the body, and that's been done only on a very select occasion, and that is where the donor essentially becomes an NDD donor and the heart is taken to cold storage and then transplant. And the last scenario is where the heart is restarted in the body of a dead donor. It is then evaluated ex situ and then restarts in the recipient. So what does that look like to us from a donation standpoint? This is a typical pathway for DCD in general. Any organ can follow this pathway. So you have withdrawal of life support, circulatory arrest, a 5-minute observation period, a declaration of death. You have organ recovery, and that can include the heart. And you either move those organs to ex situ organ perfusion or cold storage and then move to transplant. Inserting the heart in this particular pathway requires the heart to restart ex situ in the heart in the box sort of solution, but it's started outside the body of the donor, and the donor experience is not going to be vastly different. The experience in the operating room might be, but the experience for the donor body is not going to be different. So what about this concept of restarting the heart inside the body of the dead donor? This has been called normothermic regional perfusion. So the first 4 steps are the same. You have declaration of death and transport to the operating room for rapid sternal laparotomy. When that occurs, you get central cannulation of the heart at the same time as you get clamping of the cerebral blood supply. That is done by the cardiac surgeon in the operating room. Eventually, the ECMO support is weaned. Now you have a heart that is restarted inside the body of a dead donor with no cerebral perfusion and is functioning without extracorporeal support. So you've converted a DCD donor essentially into an NDD donor. You have a period of in situ heart function evaluation and organ recovery, and the pathways following organ recovery are not different. You can have ex situ perfusion, cold storage, and then move to transplant. It is important to understand that it is possible to do NRP within the abdomen and exclude the thorax and the brain. So that is where the clamp or balloon is applied at the level of the diaphragm or just above. And there's been description of that particular concept for resuscitation of abdominal organs, and you'll hear about that later today. I think it's important to understand that our forum really saw this as outside of our scope. However, we did address the death determination issues that might arise in this circumstance, and they weren't, in fact, materially different for our participants than if you went to thoracoabdominal NRP, where you included the heart and lungs and clamped the brain blood supply at the level of the arch. The question of whether there is resumption of brain circulation in a profoundly brain-injured patient where withdrawal of invasive support has resulted in apnea and then has resulted in circulatory arrest is very different than a patient who receives medical assistance in dying, has death 9 minutes later with a normal brain, and then is placed on recirculation. I think that certainly the feedback that we heard was that elevates the concern about any degree of brain perfusion that could occur in that circumstance. So what are the death determination issues that arise here? So there was a legal review done prior to our experience, and without getting into many details from yesterday, we understand that death is generally defined actually in territorial tissue gift acts. It is usually defined as accepted medical practice by at least 2 physicians and not involved in transplant. Generally speaking, that's a definition that goes across the country and doesn't vary a lot. We accepted for the purposes of this meeting, with some criticism in fact, that the dead donor rule remains the foundation of trust and integrity in the donation system, but was the question of whether we could lift the dead donor rule for purposes of donation was out of scope for our meeting. We accept in DCD a standard of permanence. That is, the heart will not restart again. Not that the heart cannot be restarted again. And we've accepted that for a long time in order to move forward with DCD. The firewall between end-of-life care providers who are responsible for death determination and the transplant surgeons has always been clear. But it's pretty clear that there needs to be peeking over that wall as the transplant surgeons are going to be responsible for ensuring that we have permanence of brain circulation and the sustained ability to maintain the determination of death. There is some differentiation between staying dead and being dead, and if you can't get your head around that, welcome to our world for the last year. But that question certainly has been raised on a number of occasions, and when we talk about converting from a circulatory determination of death to accepting that what we care about is circulation in the brain, there are some framework issues that we need to struggle with that we wouldn't have had the ability to struggle with at a meeting like we designed. It strikes me, as many of you know, I've been on the stand a lot, and lawyers like to say it's all about the language that you use to describe your actions. I think that we have moved and evolved our terminology in donation after death by circulatory criteria in a natural evolution, from non-heart beating donation to what I think is perhaps the best descriptor of that now, which is donation after death by circulatory determination. But this all comes down to where circulation can resume. Can it resume in the whole body? Can it resume in the chest and the brain? Or can it resume anywhere but the brain? That really underpins the questions of death determination that exist here and around the issue of how do we protect the determination of death as we move through the process. And without overstating it, we understand, and I would agree with Truog in some ways, to say that we are sort of twisting ourselves into pretzels to try and ensure the permanence standard is met. I think that whether we're doing it or we're not, until there's a much larger consultation, that's where we're left, and we need to ensure that we can protect the trust and integrity in the system by protecting the continued application of the dead donor rule. So what is the international experience to date in DCD hearts? So we had 3 consultants join us from the international world. We had Stephen Large join us from Papworth with a program where they do both DPP and NRP. We had Dr. Dittel join us from Australia, and Dr. Dale Gardner from the UK, where he brought his ethical and death determination journey through the UK Special Ethics Committee, etc., to our forum. There was an experience in 2008 in the United States where there were 3 pediatric heart transplants after DCD donation. This was by direct procurement. There's no pediatric device currently. Most of the discussion of this program surrounded this shortening of the observation time from 5 minutes to 3 minutes to 75 seconds, and there have been no further transplants in that program. In the UK, both NRP and DPP are used. NRP is restricted to 3 specific sites with specially trained healthcare providers. And in Australia, NRP is actually prohibited in the law because enshrined in their law is a prohibition about restarting circulation within the body. And so they can only do DPP, and that is the basis of their DCD heart program. And there have been 2 cases in Belgium with unpublished experience, both DPP. This shows the outcomes of DCD heart transplantation in short-term survival, and I think you would all agree these results are pretty impressive. And I will tell you that in discussions with Simon Messer, who was originally a fellow, has now finished his PhD, and is now a consultant in the UK, his personal belief is based on his current data, he can't demonstrate a significant difference in complication rate, hospital stay, or short to medium-term outcome between DCD and NDD heart donation. And that, to me, is a pretty phenomenal finding if we think about that injury cascade that occurs during withdrawal. Ian Ball and Kimia Honorman from London joined our planning committee in facilitating both a public and professional consultation. And kudos to them. When we were trying to struggle with how the public and how healthcare professionals would see this type of donation, Ian said, well, we should just ask them. And so that's exactly what we did. Many of you in the room have answered this survey. We surveyed a large group of healthcare providers, both donation and transplanters, and then through Ipsos Reid, over 1,000 Canadians. And what were the findings of this survey? There was generally positive acceptance. There was a drop in support that you might expect from DPP to NRP, but there was still strong support in both. There were no significant regional variations across the country between that support, although there was a bit of trend towards a bit more caution in Alberta. There was an understanding from our group that support of this type of donation didn't mean that people wouldn't have questions or didn't need reassurance or didn't need further exploration of these issues, but rather that based on the information they could be provided, that really it did mean that there was support for moving forward with this type of donation. So what were the major findings of our meeting? There's broad professional and public support. The patient partners and families at our meeting suggested that they were helped by the process in that they saw a system that was struggling with the important questions and had trust in that system, and that they felt we would be prepared to transparently answer their questions. There is a legal and coroner, there were legal consultations and consultations with the National Forum of Death Investigations and Chief Medical Examiners, and there was support for the process in which we undertook to answer these questions. There's a limited ability to understand the impact of NRP on other organs because there have been limited transplants other than heart from those patients who underwent NRP. We've already had lung and liver consultations. We have other consultations ongoing, and we asked the question about abdominal NRP. There are human resources and costs and capacity challenges within the system that we largely acknowledged but didn't feel like we had the expertise to address. But the issue of equity around the best technique access to all recipients or all potential recipients was important and was raised. I mentioned there's been about 101 cases to date. Early data you've seen suggests good short and medium-term outcomes. And there's no pediatric experience significantly or device, but perhaps in the less than 10 kilo neonate, that is the population where this has the largest potential for impact. There is insufficient data to suggest that NRP is better than DPP or vice versa. There's a possibility that there may be a signal that NRP results in a bit of superior outcomes to DPP, although certainly the signal is weak. It does offer the transplanter the ability to objectively evaluate the organ in situ, and possibly leads to less post-op recipient ECMO support post-transplant, and perhaps less time in hospital. The death determination challenges, which are not unsurmountable, still remain as we left the meeting. I think in general people supported that it was circulation to the brain that really mattered, but that the framework for death determination really needed to be addressed in a more global way. There's, in fact, almost no data that reassures us that through this technique there's no reperfusion of the brain through some collateral circulation after you clamp and tie off the arteries to the brain. There is a variable surgical comfort with being a participant in ensuring that the death determination remains and that it is part of what that it remains true throughout the surgery by the transplanter having to be involved ensuring that clamp had happened. And the work that needs to be done to address these challenges has already begun. And I think that speaks to the research nature of the research-rich nature of our audience. So the results of our large group meeting, who had 2 days to digest this, I don't think sort of materially different than what we've heard, but maybe a little bit more caution expressed in this room. So DC Hearts, essentially it was a sea of green. DPP approach was people in the room were very, very comfortable. And with the NRP approach, there was a bit more caution expressed. I want to say thank you to the collaborators that worked with us on the planning committee and the many people that were present at this meeting and the many people that really devoted the last 9 to 12 months to this process. And a special thank you to the patient and family partners. The video you're seeing is the second DCD heart transplant recipient a year following his heart transplant. So that's not something I intend to do, heart transplant or not, wouldn't change it. So thank you for your time this morning.